The next section of your text deals with blistering dermatoses, and we need to focus here on the word blister. Remember that a blister is sort of like a space or a bubble within the skin, and it arises when you have separation of layers of the skin. So if this is the epidermis and this is the dermis, imagine if the basal cells, which are down here, separated from the basement membrane of the dermis, then what would happen is you would get this big blister within the skin, or this bubble-like space that would be full of fluid. Additionally, let's imagine that you got separation of the different layers of the epidermis. So imagine if this layer here is separated from the rest, that would also produce a bubble in the skin, or a vesicle in the skin full of fluid, and again that would also be called a blister. So the idea here is that we're going to separate layers of the skin, and then that's going to produce a bubble-like vesicle within the skin, or a blister. The first disorder is pemphigus vulgaris. This is when you get autoimmune destruction of the desmosomes, and it's due to an IgG antibody against a component of the desmosomes called desmoglein. Now let's just go back and remind ourselves that if this is the dermal epidermal junction, so epidermis here and dermis here, you've got your basal cells, which are the keratinocytes that are up against the basement membrane. And then remember that the next layer is called the stratum spinosum, or the spinal layer. These cells are connected by desmosomes. Now if you've got an IgG antibody against desmoglein that's going to trash these desmosomes, when you trash these desmosomes, what's going to happen is that you're going to create a big vesicle in the skin here in between the basal cells and the rest of the epidermis. So you'd have additional epidermis up here, for example. And so that is the classic finding in pemphigus vulgaris. Now, look at this very carefully because it'll take you very far. Notice that the basal cells will be intact, so the basal layer here will be fine. And then on top of that, you'll have the rest of the epidermis, and in between, you'll have this space or this blister, which again is the hallmark of pemphigus vulgaris. Now let's look at this on histology. So here's the dermis. These are the basal cells. Here is the blister. And then here is the remainder of the epidermis that's been separated from the basal layer. Why has it been separated? Because you have an IgG antibody against desmoglein, which is a component of the desmosomes, and so you've separated some of the cells that were connected by desmosomes. Now a few terms just to be aware of looking at this picture. One thing that's going to happen is you get acantholysis, and acantholysis is when you separate keratinocytes. So of course we have acantholysis of the stratum spinosum, which then results in this blister. Remember that the basal cells are going to remain attached, and the reason why the basal cells remain attached is because the basal cells are attached to the basement membrane via hemidesmosomes instead of desmosomes. And so this is also called the tombstone appearance because it appears that you have these little tombs sitting here against the basement membrane. Now another important consequence clinically from this image is that this epidermis is relatively thin. Notice that it doesn't contain all of the layers, it just contains some of the layers. And so the wall, which is up here, the wall of this blister will actually be very thin-walled, quote-unquote, so the bullae or the blisters will rupture easily. And when these rupture, you'll get these shallow erosions with dried crust on the surface of the skin. An additional important finding is that when you have a patient with pemphigus vulgaris, you can do a biopsy, and immunofluorescence can be performed. And when immunofluorescence is performed, it will show IgG antibody surrounding the keratinocytes. And they call that the fishnet appearance of immunofluorescence. One of the hallmarks of pemphigus vulgaris, and particularly high yield, is that it can involve both the skin and the oral mucosa. So it's very important to note that pemphigus vulgaris can also involve the oral mucosa. The next disorder is bullous pemphigoid. This is when you get an autoimmune destruction of the hemidesmosomes. Let's go back and remind ourselves. This is the epidermis, this is the dermis. Recall that the basal cells are connected to the basement membrane via hemidesmosomes. If you destroy these hemidesmosomes, the entire epidermis will be lifted off the dermis, and you'll get a blister in between the epidermis and the dermis. And so this is the basic understanding of bullous pemphigoid. Now let's go back and read your text. You get autoimmune destruction of the hemidesmosomes. It's due to an IgG antibody against the basement membrane. Now because the IgG antibody is going to line up against the basement membrane, that's going to give you a linear immunofluorescence. It presents as subepidermal blisters of the skin. Why subepidermal? Because you've lifted off the epidermis from the dermis, and so the blisters will be underneath the epidermis, and the oral mucosa would be spared. And that's important because clinically it helps to distinguish the disease from pemphigus vulgaris, which normally involves the oral mucosa. An additional important clinical finding will be that you'll have tense bullae that do not rupture easily. Now, why do these blisters not rupture easily? Because the wall is thick. It contains the entire epidermis. And this can be contrasted against pemphigus vulgaris because remember that in pemphigus vulgaris you had bullae that ruptured easily because the wall was much thinner, and that was because it was only part of the epidermis. Here's a classic histology just to remind you of some of the principles. So here's the epidermis, here is the dermis, here's the basal cells, and you can clearly see here that you've got separation of the epidermis from the dermis, producing a blister. Of course, you've lifted off the basal cells, so there are no basal cells present here. This results in a thick wall, which clinically does not rupture as easily. And in addition, if you did immunofluorescence, you would see antibody lining up against the basement membrane in a linear pattern. So these are all some of the key hallmarks of bullous pemphigoid. Here's a clinical picture of bullous pemphigoid, and you can see that many of these vesicles have not ruptured, again, due to the fact that they have a thick wall. Dermatitis herpetiformis is when you get autoimmune deposition of IgA at the tips of the dermal papillae. Let's go back and remind ourselves. Here is the epidermis. Here is the dermis. These are the dermal papillae. And remember that within the dermal papillae, you've got these blood vessels which help to feed the epidermis. Now what's going to happen here is you're going to get deposition just at the tip of the dermal papillae, for example, here and here. Now when you get this deposition, that's going to result in the tiny blister at the dermal papillae. And these tiny blisters, they resemble the tiny vesicles that you see in herpes. And so hence the name dermatitis herpetiformis. It's forming little blisters that mimic the vesicles that you would see with herpes. Now again, this is going to present as pruritic vesicles that are grouped together. And finally, there's a strong association with celiac disease. This is very high yield. The IgA antibody that was depositing at the tip of the dermal papillae, these are antibodies against gluten that cross-react with reticulin fibers that attach the basement membrane to the dermis. And that's particularly high yield because if you treat the celiac disease with dietary control, in the same way that the celiac will resolve, the dermatitis herpetiformis will also resolve. Here's a picture of dermatitis herpetiformis just to show you that you've got these grouped tiny little vesicles which are herpes-like lesions. Again, this will resolve with a gluten-free diet. The final disorder in this section is erythema multiforme. This is when you get a hypersensitivity reaction which leads to the formation of a targetoid rash with bullae. It most commonly is associated with HSV infection, but it can also be seen with mycoplasma, with some drugs such as penicillin. It can be seen as a consequence of autoimmune disease. For example, lupus patients can develop erythema multiforme, and it can also be seen in association with malignancy. But again, the most common association is HSV infection. Here's a clinical image of erythema multiforme. Note that you have a bunch of these erythematous rashes, hence the term erythema, and notice that they're multiple, hence the term multiforme. If you look carefully, you can see that some of these lesions have a little bit of white in their center, and the reason that they have white in their center is because there is necrosis going on in the very center of that lesion, and that's what gives it what we call the targetoid appearance. Erythema multiforme normally involves the skin. However, if there's oral mucosa involvement with fever, then we call that whole syndrome Stevens-Johnson syndrome. And then there's a super severe form of Stevens-Johnson syndrome, which is called toxic epidermal necrolysis. And in TEN, you get diffuse sloughing of the skin, which sort of resembles a large burn. And TEN most often arises due to an adverse drug reaction. Of course, TEN is a medical emergency. And that concludes this particular section.